Good evening and thank you for joining us for the website on dysphagia. The scope of this presentation is to reflect on practice points pertinent to normal and disordered swallowing and related functions. Dr. S. L. Brewer will be providing the viewpoint on the subject. Dr. S. L. Brewer is an eminent gastroenterologist practicing at the Indraprastha Apollo Hospitals in New Delhi and was a former director, professor and head of the Department of Gastroenterology, G.B. Pant Hospital, New Delhi. Dr. Brewer specializes and has years of teaching experience in the field of gastrointestinal and liver disease, therapeutic endoscopy and liver transplantation. He is a recipient of numerous achievement awards and has various fellowships to his credit. Without further ado, I would like to introduce you to the presentation on dysphagia by Dr. S. L. Brewer.
Good evening, ladies and gentlemen. I welcome you all to this web seminar on dysphagia. Dysphagia indeed is a very important problem. We chose this topic for two reasons for this seminar. Firstly, dysphagia affects all age groups, children, adults, elderly people. And secondly, all of us, general physicians, internists, gastroenterologists, surgeons, pediatricians, all see this kind of problem in our day-to-day practice. Now, let us first define what we mean by dysphagia. Basically, in dysphagia, the patient is not able to swallow the food. There may be difficulty in transferring the food from the buccal cavity down into the esophagus. This is called oropharyngeal dysphagia or transport dysphagia. The patient is not able to define the complaint very clearly and they use all kind of terms. Somebody will say that the food just sticks, somebody will say the food hangs on, and some patient will say that he just simply cannot push his food down the esophagus into the stomach. Now, broadly speaking, the dysphagia can be divided into two subgroups. One is the oropharyngeal dysphagia. The second group is the esophageal dysphagia. Here the defect lies in the esophagus. The patient is able to push the food from the pharynx down to the esophagus, but is not able to transport the food across the esophagus down into the stomach, and therefore this is also called as transport dysphagia. Before we proceed further, let us look briefly at the normal process of swallowing. As you all familiar, in the swallowing process, the aerodigestive tract channels air for the breathing from the nose, mouth down through the larynx into the trachea. And similarly, the air is breathed out from the trachea, larynx into the mouth and nose. The aerodigestive tract is reconfigured from the air channel to a food propelling mechanism during the act of swallowing. During the act of swallowing, when the patient is swallowing food, there is a closure of the larynx by the epiglottis, the vocal cord constricts, so the food is transferred from the pharynx into the esophagus and is not allowed to go into the larynx and the trachea. Once the food has gone from the mouth into the pharynx, then you will find that the upper esophageal sphincter will open and the food is transferred into the esophagus. After the food bolus has entered the esophagus, the upper esophageal sphincter would close so that the food does not come back into the pharynx, and then the food is transferred from the upper end of the esophagus down into the stomach. Now, this is what normal mechanism of swallowing is. If the normal process is not there, there is some kind of disorder, the patient will not able to swallow the food. And as I already mentioned, this can be a transport dysphagia, which is also called oropharyngeal, or this can be a transport dysphagia, which is called esophageal dysphagia. In the oropharyngeal dysphagia, there is a discoordination in transferring the bolus from the pharynx to the esophagus, and these patients commonly have symptoms like gagging, coughing, nasal regurgitation, pulmonary aspiration. The risk of pulmonary aspiration is quite high in these patients. And since the patient is not able to swallow the food, the long-term complications of dysphagia would manifest in the form of weight loss, malnutrition, and these patients also have pulmonary complications because of the repeated aspirations. Most patients, vast majority, almost close to 80%, who have this kind of oropharyngeal dysphagia, the cause is a neuromuscular disorder. And this may be in the form of cerebrovascular extents, polymyositis, dermatomyositis, scleroderma, myasthenia gravis, myopathy, etc. In addition to these neuromuscular disorders, a small number of cases will be due to a local pathology like pharyngitis, large aphthous ulcers, or some candida infection, or peritonsillar abscess, or these patients may also have carcinoma of the tongue or carcinoma of the pharynx, and these again can produce oropharyngeal dysphagia. If there is inadequate lubrication because of lack of saliva like scleroderma, again the patient will have difficulty and may have oropharyngeal dysphagia. On the other hand, in the other group of patients like the esophageal dysphagia, there is basically no difficulty in transferring the food from the mouth into the esophagus, but then the food is not transported properly from the upper end of the esophagus down into the stomach. The patient will complain as if the food is getting stuck up, some in the chest, maybe upper part of the chest or lower part of the chest. These patients who have the esophageal dysphagia, the risk of complication like aspiration, nasal regurgitation are much less compared to the oropharyngeal dysphagia. As for the long-term complication or dysphagia concerned like malnutrition, weight loss, they are equally common in this kind of dysphagia also. Again, the esophageal dysphagia is most commonly caused by obstructive diseases, carcinoma in the elderly people. You may have benign stricture like peptic stricture or corrosive stricture, foreign body ingestion, diverticulum, and some cases will have extrinsic compression of the esophagus. A relatively small number of patients who have the esophageal dysphagia, the cause may be motor disorder like achalasia, peristaltic dysfunction, diffuse esophageal spasm. And also it is important to remember that some patients may have inflammatory lesion, esophagitis, which causes the esophageal dysphagia. Now let us look at the common causes of oropharyngeal dysphagia. The most common causes, as I already mentioned, are the neuromuscular causes. Some patients will have structural disorders, and in some cases the cause may be iatrogenic. Neuromuscular disorders like stroke, cerebral palsy, multiple sclerosis, myasthenia gravis, amyotrophic lateral sclerosis, Parkinson's disease, myopathy, these are the common causes of this kind of disorder. In the structural causes, it is important to remember, although these are some of these are uncommon, like Zenkel's diverticulum, head and neck tumors, cervical spondylosis, vertebral osteophytes, and some pharyngeal webs in Plummer-Vinson syndrome will be the causes of this kind of dysphagia. Iatrogenic causes, radiation therapy to this area may cause injury to the oropharyngeal area. Corrosive injury can be another cause, and uncommonly anticholinergic medication taken in large doses may cause dryness of mouth and may cause oropharyngeal dysphagia. What about esophageal dysphagia? Esophageal dysphagia can occur because of common causes which are mechanical causes, or this may be due to neuromuscular causes. The mechanical causes which account for a much more higher number of patients: malignancy, peptic stricture, corrosive stricture. Corrosive strictures, you should note, are commonly seen in our country, although these are not so common in the western population. Radiation induced esophageal stricture, patient may have esophageal rings and webs, and sometimes patient will have pill or medication induced esophagitis and esophageal stricture, divertical of the esophagus, and extrinsic compression of the esophagus by lymph nodes, osteophytes, or rarely by blood vessels. Now, in some patients, the esophageal dysphagia is caused by motility disorders. There are several motility disorders which can produce this kind of problem, but the commonest in our practice would be achalasia. In achalasia, the peristaltic function is not normal. The lower esophageal sphincter is not able to relax with the oncoming bolus, and these patients thus are not able to swallow the food properly. Diffuse esophageal spasm, hypertensive lower esophageal sphincter, scleroderma are other conditions which can cause esophageal dysphagia. However, these are not so common, and achalasia remains by and far the more common motility disorder of the esophagus as the cause of dysphagia. How do we proceed to making a diagnosis in these patients? I must emphasize that in this problem, history taking is very important, and we should be able to decide as to what is the type of dysphagia which the patient is having. Most patients can localize the dysphagia site either to the upper or the lower part, but please remember that this localization is not always accurate. The patient may point out that he feels the food gets stuck up in the upper part in the suprasternal notch, while the actual obstructing lesion may be lower down and vice versa. and in some patients therefore, there is a considerable overlap. So, this is important point, but is not always very accurate. Now, recognizing dysphagia, as I mentioned, that history is very useful to make a distinction whether a patient is likely to have oropharyngeal dysphagia or he has got esophageal dysphagia. If a patient is giving history of frequent coughing, choking while he makes an attempt to swallow the food, or there is difficulty in initiating the act of swallowing, or the food sticks in the throat, or there is a history of nasal regurgitation, frequent pulmonary aspiration, you should think that this is likely to be oropharyngeal dysphagia. On the other hand, if the patient says that there is no difficulty in initiating the process of swallowing, he feels that the food is going down the throat normally, but it gets stuck up somewhere in the chest, and there can be drooling of secretions, and history of nasal regurgitation, pulmonary aspiration is not very common. This would go in favor of esophageal dysphagia, although these kind of pulmonary complications can occur uncommonly in esophageal dysphagia also. Now, sometimes there are few questions which you will ask, and they can give you tremendous information, and it helps us in making a better diagnosis. I think one of the questions we should ask the patient: do you cough, or do you get choking, or you find a feeling of the food getting stuck up in your throat and coming out of your nose? Do you feel as if the food is getting stuck right within the very first second or 2 seconds after you swallow the food? If the history is positive for these kind of points, these would indicate that we are dealing with oropharyngeal dysphagia. Ask the patient, do you have difficulty swallowing liquids, solids, or both? It is also important to ask the patient if he has got history of dysphagia for solids only, or does he have dysphagia for solids and liquids. If a patient has history of dysphagia in the beginning and over a period of time he develops dysphagia for liquids also, this is called progressive dysphagia. Progressive dysphagia would indicate that we are dealing with a mechanical obstructive lesion like stricture or malignancy. On the other hand, if the patient does not have a progressive dysphagia, there is a non-progressive dysphagia, or he has dysphagia both for solids and liquids, and there is no further progress in the difficulty of swallowing over a period of time, then we will think of some neuromuscular disorder or esophageal rings and webs. We also the patient, are your symptoms constant, permanent, or do you get this dysphagia intermittently? If the patient says that the symptoms are intermittent, episodic, think of lesions like esophageal rings or webs. In these patients, the symptoms are not persistent all the time. We ask the patient, do you take medications without adequate amount of fluid, or do you take medication while lying down? If the patient gives a positive history for these 2 points, think about pill-induced esophagitis and esophageal stricture. These patients frequently take some antibiotic or non-steroid anti-inflammatory drugs. They do not consume enough of water, or the patient takes the drug lying down. The drug gets stuck up in the esophagus, causes ulceration and causes stricture, and this is a cause of dysphagia. We should also ask the patient that do you have any history or any medical condition where your immune status is compromised. Suppose a patient has got HIV virus infection, a patient is on prolonged steroid therapy, a patient has got chemotherapy, or patient is renal or hepatic transplant. These patients are immunocompromised, and if they complain of dysphagia or dinophagia, you should think of any infectious esophagitis due to some viral etiology or fungal etiology like Candida, and the viruses which commonly produce esophagitis in this situation are herpes and CMV esophagitis. You should also make it a point to identify any alarm symptoms in this patient. As I mentioned, in some patients the dysphagia is due to benign lesion which may not be very worrisome. On the other hand, there may be lesion which may be quite worrisome, and therefore you should look for alarm symptoms, and so that we do not miss some such serious kind of lesion. Any symptoms suggestive of oropharyngeal or laryngeal carcinoma, any history suggestive of cerebral stroke, head injury, Parkinson's disease, multiple sclerosis, myotrophic lateral sclerosis, esophageal carcinoma, all these are serious conditions, and if you take the proper history, you will be able to get the diagnosis in most of these patients. The quality, the location, time course, and frequency of dysphagia also helps us to make a better diagnosis. Is the food sticking after you have been able to push it through the throat into the esophagus? Does the patient feel as if the food is getting stuck up some in the retrosternal area? Think about esophageal dysphagia. If the patient, as I mentioned already, if he feels the food gets stuck up in the throat area and there is a frequent history of nasal regurgitation, frequent history of pulmonary aspiration, think about oropharyngeal dysphagia, or the patient has got some cerebrovascular accident or some neuropathic disorder, neuromuscular disorder, you should think about oropharyngeal dysphagia. Are the symptoms episodic? Are the symptoms progressive? Are the symptoms permanent? If the patient says the symptoms are progressive, then you think of some kind of mechanical lesion like stricture or cancer. If the patient says the symptoms are episodic, he gets dysphagia once in 2 months, once in 3 months, then think of lesion like esophageal rings and webs. And how long the patient have had this symptom also will give us some information. If the history is short of a few months, we think of some peptic stricture, or we think of some malignant disease process. If the patient say the history is long, 3 years, 4 years, 5 years, then think of some neuromuscular disorder or esophageal rings and webs. What are the diagnostic modalities which are available for these patients? Again, I would like to emphasize that if you take a proper history, this would be a very useful clue for us, and we will be able to get further confirmation by these modalities. Barium swallow examination is very useful. When you suspect an obstructive lesion, do a barium swallow examination. In fact, barium swallow and upper GI endoscopy are complementary to each other. If you suspect any esophageal motor disorder, you do a barium swallow examination. Although in barium swallow is not the diagnostic test in this patient, you will have to do the manometric studies. Upper GI endoscopy is again a very important investigation, especially in patients where you suspect malignancy or benign strictures. Not only you are able to have a visual impression about the lesion, you can also take biopsies, you can also take cytology. Manometry is helpful in many patients where you are thinking about some neuromuscular disorder. Unfortunately, manometry is not available in many centers, but if available, it is very useful, especially for a patient like achalasia, patient with diffuse esophageal spasm, patient with the hypertensive lower esophageal sphincter. And video radiography, again, this facility is not available in many centers, but if available, this can be also useful in the evaluation of these patients. Recognizing the associated symptom along with the dysphagia can also be very helpful. If a patient gives history of gurgling sounds, if a patient gives history of bad breath, think about Zenker diverticulum. The food stays in the diverticulum for a long time, and he complains of bad breath, halitosis, and because the food and secretions stay in this diverticulum, it produces gurgling sounds. Is the dysphagia accompanied by pain, which is called as odynophagia? If the patient says that dysphagia is associated with pain, has odynophagia, then you think of infectious esophagitis like Candida and viral esophagitis. Ask the patient, do you have to ever bear down or raise your arms over your head or shoulder to help a food bolus pass? If yes, motor disorders like achalasia. Are your symptoms worse when you take very hot or very cold liquids? Again, motor disorders like achalasia. Do you have a very long standing history of heartburn? Think of peptic stricture. Is there any history of corrosive ingestion in the recent past? Think of corrosive stricture. Is there any history of ingestion of any pills, antibiotics, NSAIDs? Think about esophagitis. Are your symptoms worse when you swallow very cold or very hot foods, motor disorders? And do you suffer from any allergies like asthma or dermatitis, atopic dermatitis? You think of eosinophilic esophagitis. So these symptoms sometimes give us a very valuable clue towards the cause of dysphagia. Briefly, I have already mentioned about odynophagia, but I like to mention about it because this is a very important point. And if you take this history, whether the dysphagia is accompanied by pain, and if you have got odynophagia, you must make it a point to exclude infectious esophagitis. The pain in this patient may be very mild, or sometimes the pain is very severe, stabbing pain, so severe the patient is scared even to swallow his own saliva. Now, please remember, if the patient complains of odynophagia, you should make it a point to exclude corrosive injury, infectious esophagitis, Candida, herpes, CMV esophagitis, radiation-induced esophageal injury, and peel esophagitis. These are the common conditions which will cause odynophagia. These conditions do not produce simple dysphagia. The diagnosis of odynophagia, the most important is the careful history, and secondly, we can do the GI endoscopy and we evaluate the mucosa and look for any evidence of Candida, look for any evidence of viral esophagitis. Since we talked about the pill-induced esophageal ulceration stricture, it is important for us to know which drugs commonly can cause this kind of problem. Amongst antibiotic, the most common antibiotic which cause esophageal ulceration are doxycycline, tetracycline, clindamycin. Then another important group of drugs is the non-steroidal anti-inflammatory drugs, potassium chloride tablets, quinidine gluconate, and sometimes iron preparations. Then there are medications which are associated with xerostomia like anticholinergic drugs and alpha-adrenergic blockers, angiotensin converting enzymes. Then there are medications and hormones and foods which are associated with reduced lower esophageal sphincter tone and reflux like butyl scopolamine, theophylline, calcium antagonists. But in practice, these are not very important causes. You should remember antibiotic, non-steroidal anti-inflammatory drugs, theophylline, quinidine, and iron preparation, which can commonly cause pill esophagitis and can cause esophageal dysphagia. A simple approach towards the diagnosis of dysphagia is shown in this chart. Ask if the patient has got difficulty in initiating the act of swelling and he has any symptom like choking, coughing, nasal regurgitation. If the patient has these kind of symptoms, then you are dealing with oropharyngeal dysphagia. No further work may be needed. If the patient says that he is able to push the food down the throat into the esophagus, but then the food sticks and he has a sticking sensation somewhere in the chest, you think about esophageal dysphagia. The next question is, does this patient have dysphagia only for solids or does he have dysphagia for solids and liquids both? If the patient has dysphagia for solids only, then this patient has got mechanical obstruction. This can be intermittent, and if the history is of intermittent long standing duration, then we think of some esophageal rings and webs. If the patient says that his dysphagia is progressive over a period of time, in addition he has a history of heartburn for several years, then we think of peptic stricture. If this is an elderly individual, more than 50 years, more than 60 years, he has associated anorexia, he has got weight loss and got progressive dysphagia, you must think of esophageal carcinoma. Now suppose the patient says that his dysphagia is for solids and liquids both. The dysphagia is equally common for liquids, not only for solid, and relatively non-progressive. Here we think of not mechanical obstruction, here we think of some neuromuscular disorder. If this dysphagia is intermittent and the patient also gives history of chest pain, which can be a very significant symptom in this patient, think of diffuse esophageal spasm. If the patient says he has heartburn also for a long time, in addition to these kind of symptoms, think of scleroderma. If the patient has got respiratory symptoms, think about achalasia. So thus this simple approach will be very helpful in making a diagnosis of esophageal dysphagia. After this, we go on to the evaluation and management of oropharyngeal dysphagia. Here again, history and physical examination is the most important, and laboratory tests can be decided depending upon the patient's underlying condition. If a patient has got no evidence of systemic disease, nasoendoscopy may be evaluated, may be needed to evaluate for any structural cause of dysphagia, and you will be able to identify certain structural lesions like tumors, Zenker's diverticulum. If a patient has got neuromuscular dysfunction without any specific syndrome and there is no history of any severe, there is no history of head and neck trauma, then video fluoroscopy swelling if available, this can be very helpful for us to evaluate these patients. And depending upon the cause, you are able to treat this patient. By and large, there is not very specific treatment and it is not possible to intervene for most of these patients, but by and large they got a neuromuscular dysfunction as a cause. The management options for esophageal dysphagia on the other hand are many. Depending upon the cause of the dysphagia, the management option, whether it is a conservative treatment or we need some kind of endoscopic treatment or surgical treatment, will be decided depending upon the cause of dysphagia. If a patient has got diffuse esophageal spasm, medical treatment like nitrates and calcium channel blockers may help, and sometimes serial dilatation or longitudinal myopathy may be needed. If a patient has got achalasia, calcium channel blockers may be tried. By and large, these patients do not respond very well to the medical therapy, and the treatment of choice, there are two options: either we do pneumatic dilatations or we do surgery. In most patients, most centers, pneumatic dilatation is done first. The success rate of pneumatic dilatation is about 65 to 75%. The cost is low, and if a patient does not respond to pneumatic dilatation, surgery may be done. However, this subject is debatable, and some surgeon would like to recommend the surgical treatment as the first option, like Heller's myectomy, which can be done by the laparoscopy approach. So, you have to discuss this with your patient whether he wants pneumatic dilatation or he wants surgery. If a patient has got peptic stricture or corrosive stricture, what do you do then? Peptic stricture, the most important is that you give the anti-reflux treatment with proton pump inhibitors and we dilate this patient. The endoscopy dilatation is very effective. Almost 100% of the patient can be treated by endoscopy dilatation combined with PPI therapy. If a patient is not responding to the medical therapy, then surgical treatment like fundoplication we can consider. The corrosive stricture, as I mentioned, again most patients with corrosive stricture can be treated by endoscopy dilatation. We have over the years treated a large number of patients with peptic and corrosive strictures, and in corrosive strictures again the success rate of endoscopy dilatation is close to 90%. Only in those patients where we are not able to treat the corrosive stricture by endoscopy dilatation, we will refer the patient to surgery. If a patient has got infectious esophagitis, and as I mentioned, these patients will have odynophagia, we will treat with antibiotics. If the patient got candida, treat with nystatin. If a patient got viral esophagitis, treat with antiviral drugs. There is no invasive treatment available for this group of patients. If a patient has got esophageal cancer, of course surgery, radiotherapy or chemotherapy can be opted. To discuss with the patient depending on the site of the disease, depending upon the extent of the disease, everything has to be considered to decide what would be the optimal treatment for this patient. If a patient has got Zenker diverticulum, may need surgery, endoscopic treatment can be done in this patient in expert hands. If a patient has got Shasky ring or rings, webs of other type, again endoscopy dilatation is very easy and can be safely done in this patient. I would briefly like to mention a word about globus sensation, because this is a problem which is very commonly encountered in general practice. What do you mean by globus sensation? Well, here the patient complains of some kind of feeling of a lump in the throat. In fact, the patient is not very clear and sometimes they give very vague description of the symptoms. Most patients, however, will say that there is a lump in the throat. Some patients will say that they feel some kind of tightness, some kind of choking or something stuck in the throat. Now, how do we decide whether this is globus sensation or there is something else, some kind of mechanical obstruction? Please remember, in globus sensation, this symptom dysphagia is not related to eating. The patient will have this sensation all the time even when the patient is not eating. So, if the patient has this kind of symptom, think of globus sensation, whereas a patient has got peptic stricture or patient with cancer esophagus, if he is not eating, there will be no dysphagia. Dysphagia will occur only when the patient is swallowing food. How do you manage globus sensation? Exclude organic disorder, that is the most important. You may have to take a detailed history and may need to do the barium swallow and upper GI endoscopy. Detailed history for psychological or emotional problems. Very often these patients have underlying anxiety, depression, panic disorder or hypochondriasis. If a patient got heartburn and even if the heartburn is not present, it is recommended that you might give a course of PPI, a course of proton pump inhibitors in double the dose as a therapeutic trial. Most patients would respond to this treatment. If a patient has obvious anxiety symptoms, he has obvious emotional problems, and especially if he has failed PPI therapy, it would be important to evaluate his psychological problem, and you may have to take the help of a psychiatrist also. I think after this introduction to the subject of dysphagia, I would just briefly present few cases so that you are able to use this information in your day-to-day practice. Now, firstly, these two cases to illustrate the oropharyngeal dysphagia. First is a 60-year-old male with the past medical history of hypertension, dyslipidemia, diabetes, and now he has consulted a physician for sudden onset of inability to move the right arm and the right leg. The patient also has slurring of speech with difficulty in swallowing. Now, this patient has got comorbidity like diabetes, hypertension, he has a sudden onset of hemiplegia, he has got symptoms of dysphagia, slurring of speech. All this point out that this is oropharyngeal dysphagia due to the cerebrovascular accident. A second patient is a 45-year-old lady who presents with gradual onset or difficulty in swallowing. The symptoms occur a few minutes after swallowing and accompanied by nasal regurgitation, and also there is a change in the tone of her voice. She also gives history of cough every time she tries to eat. Symptoms are preceded by difficulty in climbing stairs and combing her hair. Now again, this patient has got gradual onset of dysphagia. She also has got symptoms of muscle weakness, and this is suggestive of underlying muscular disorder. This patient may have myopathy or myasthenia gravis. The third patient is a 63-year-old male who presented with 2-month history of progressive dysphagia. The patient also gives history of significant anorexia and significant weight loss. What next would you do in this patient? Would you do barium swallow examination, endoscopy or manometry? In this patient, I would recommend a barium swallow examination for the very simple reason that we are suspecting here esophageal cancer because of his age, because of his anorexia and weight loss and progressive dysphagia. Barium swallow would be very helpful and is complementary to the upper GI endoscopy when you are suspecting a malignancy. After you have done the barium swallow examination, I would recommend upper GI endoscopy to confirm the finding of barium swallow, and also we can take biopsy cytology to confirm the tissue diagnosis. Manometry in this situation is not required. We are not thinking about any neuromuscular disorder. What treatment would you recommend for this patient? Well, if you have confirmed that this patient is getting esophageal cancer, he would need further evaluation to find out which part of the esophagus is involved, what is the disease spread like, is it confined onto the esophagus, is there local spread or distant spread, and what is the patient general overall condition. Depending upon all these factors, you decide whether the candidate is fit for radical therapy by surgery, or is a candidate for radiotherapy, or is a candidate for the chemotherapy. And sometimes a patient is not fit for radical therapy, he may need only palliative treatment, and the palliative treatment can be provided by radiotherapy, chemotherapy or endoscopic palliation. Next is a case, 30-year-old male who complains of long-standing heartburn and progressive dysphagia for the last 1 year. The patient has lost some weight, but there is no loss of appetite. What investigation would you do? Well, now the history is pointing out that we are dealing here with a peptic stricture, because this patient has got long-standing history of heartburn, suggesting gastroesophageal reflux disease, and now for the last 1 year he has got progressive dysphagia. In this patient, therefore, I would like to do the barium swallow first, followed by upper GI endoscopy, and upper GI endoscopy will confirm. If I need it, I can take the biopsies. The treatment plan, after having confirmed that this is peptic stricture, these patients are best managed by endoscopy dilatation combined by PPI therapy. More than, I would say, 96-97% of this patient can be managed by medical therapy. Only few patients who do not respond to medical therapy would be referred for surgery. The next history is of a 3-year-old child who is brought by his parents with history of dysphagia for last 6 weeks following accidental ingestion of sulfuric acid. You might be wondering why the child has ingested sulfuric acid. I might like to point out here, we have been seeing over the last 15-20 years so many cases of corrosive poisoning, corrosive acids, alkali poisoning. Unfortunately, in our country, hydrochloric acid, sulfuric acid are kept in Coca-Cola bottles, and they are used commonly as bathroom and toilet cleansing agents because they are cheap and they are easily available. And the child very often swallows them by accident and becomes a victim of accidental ingestion, develops severe injury to the upper esophagus, lower esophagus, and may develop injury to the stomach and duodenum and can develop esophageal stricture. Now, since this patient has come with history of dysphagia, the first investigation I would like to do is a barium swallow examination. In fact, I would do a barium meal examination, not only swallow, so that I like to assess his esophagus and also like to see his stomach and duodenum. Esophagus barium will give me an idea whether you got one stricture or you got multiple stricture. These patients can have multiple strictures. What is the location of the stricture? Is it located in the upper part, middle part or lower part? And also, as I said, that I would like to do upper GI series, not only barium swallow, because these patients may have injury to the stomach and duodenum by the corrosive substance. It's important therefore to evaluate their stomach and the duodenum in order to plan the optimal treatment. How would I treat? Suppose I do the barium swallow and I find that the child has got esophageal stricture. Stomach and duodenum have been spared. This child is best managed by endoscopic dilatation. We have been successfully managing these children, adolescents over the last 2 decades with endoscopic dilatation with very satisfying results, and we are able to save a large number of them from surgery. More than 90 to 95% of the children, adolescents have been treated with endoscopic dilatation with very good results. The next is a 45-year-old female who presents with a history of dysphagia. Now this dysphagia is non-progressive. She got dysphagia both for solids and liquids for the last 2 years. Her appetite is normal, but she has lost some weight, 1 or 2 kilograms. The first question is, what is the likely diagnosis? Now if you look at the history, the most likely diagnosis here is achalasia, but this lady has a long history of 2 years. Her appetite is normal, she has lost some weight, and this is non-progressive dysphagia, and she had dysphagia both for liquids and solids right from the very beginning. So I would suspect on this history, achalasia being the commonest neuromuscular disorder, I would think of achalasia the first possibility. What investigation? Barium swell examination would be very helpful for us. In most cases, we can make a fairly good and reliable diagnosis of esophageal achalasia. Some patient, it's not possible to be absolutely sure on barium swell examination and endoscopy, and esophageal manometry would be very helpful. Unfortunately, manometry facilities are not available at many centers, but achalasia is one condition where manometry would be important if available. The treatment plan, after having confirmed that we are dealing with achalasia, there are 2 options. Either we do pneumatic dilatation or we do surgery. At the moment, a debate is going on in the literature whether pneumatic dilatation is the treatment of choice or surgery is the treatment of choice. Most physicians would do a pneumatic dilatation. As mentioned earlier, the success rate is pretty good. 65 to 75% of this patient would be relieved of the dysphagia. The cost is much less, and the patient can discharge home after 6 to 8 hours of observation in the hospital. If a patient is not responding to pneumatic dilatation, then obviously surgery can be considered, and surgery is Heller's myotomy, and these days it can be done by laparoscopy means. And in fact, as I mentioned, that some centers would advocate that these patients, the treatment of choice may be laparoscopic Heller's myotomy. To summarize, therefore, ladies and gentlemen, I would say that dysphagia is a very important symptom, and please always take this symptom seriously, and these patients would need proper evaluation. What is the duration of dysphagia? What type of difficulty the patient has in the swallowing? And what is the frequency of the symptoms? These all give us some important clues in making a diagnosis. At the very outset, try to distinguish whether your patient has got oropharyngeal dysphagia or has got esophageal dysphagia. Please remember that localization of symptoms is useful, but is not always an accurate indicator of the site of obstruction. Dysphagia in young persons, more commonly in males and females, may be second to eosinophilic esophagitis, especially in patients with disorders such as asthma and atopic dermatitis. Why I am pointing it out that this entity is being recognized more and more commonly in the recent past, and many of us may not be aware, and therefore we are likely to miss this diagnosis. Progressive dysphagia most often due to a mechanical obstruction, whereas dysphagia to solid and liquid both is often due to a motor disorder. Dysphagia can occur from extrinsic compression of the esophagus by lymph nodes, by blood vessels, and this entity should also be kept in mind. Please remember the bottom line or the bottom carry home message which I want all of you to remember, that in your day-to-day practice the common causes of dysphagia would be peptic stricture, corrosive stricture, malignancy esophagus, achalasia, esophageal rings and webs. If you remember these few conditions, you will be able to make the diagnosis in almost more than 98% of the cases of esophageal dysphagia. As far as the oropharyngeal dysphagia is concerned, I have already mentioned about it. Comments by anyone in the audience. Thank you very much.